and we will get going. So I know people are coming on, but we're just going to get started. Thank you all for coming to another trauma conference. Today, Maggie Spruce, one of our second year surgery critical care fellows, is here to talk about blunt cardiac and cerebrovascular injury. And with that, Maggie, floor is yours.
All right, thank you. Good evening, everyone. I appreciate all of you joining. As Dr. Knittel said, I'm one of the second-year trauma fellows here at WashU. And tonight I'm going to discuss two relatively common conditions in trauma: blunt cardiac injury, which I'll refer to as BCI, and blunt cerebrovascular injury, which I'll refer to as BCVI. I have no disclosures, but I have to tell you all that as a member of the U.S. Air Force, these views expressed here are my own and don't reflect the official policy or position of the U.S. government, Department of Defense, Department of the Air Force, WashU, or Barnes. So BCI and BCVI are both frequently discussed injuries in trauma, but it remains unclear who should be screened for these conditions and how they should be managed. Many have observed that they are rarely clinically significant. Some may argue that we're overdoing it, spending unnecessary resources on clinically insignificant injuries. Some may argue that we're underdoing it, missing injuries, and thereby delaying or withholding treatment that may prevent complications. These questions come up all of the time in the ED and in our morning conferences with no clear consensus. So tonight we're going to dive into these topics a bit and see if we can come up with a consensus for screening and management and determine if we are in fact over or underdoing it. So first we'll discuss BCI. The incidence varies widely in the literature, likely because there's really no clear definition of what it actually is. What is clear is that clinically significant BCI is much less common than those who are diagnosed with the condition, at around 3%. No one knows the true mortality rate of those with BCI, but it is low in the absence of TTE abnormality. If there's true BCI with echo abnormality, then that mortality rate approaches 20%. BCVI is much easier to find. It's now simply an imaging finding on CTA. Its incidence is about 1 to 3% of blunt trauma patients. Stroke rate varies widely dependent upon what you read, but anywhere from 3 to 25%. And that could be considered, one definition of clinical significance in that context. Stroke-related mortality has been reported anywhere from 13 to 50%. So if anyone has any opinions before we get started, please share. If not, we'll go ahead. So what is blunt cardiac injury? It is simply any cardiac injury caused by trauma. This is obviously an extremely vague definition with no clear diagnostic criteria. Of note, the term cardiac contusion is no longer really an accepted term. At least with our current imaging technology, a cardiac contusion can truly only be diagnosed histologically via autopsy. And of course, we hope that the vast majority of our patients will not require an autopsy, so that term is really irrelevant today. The mechanism of BCI involves compression, deceleration, blast, and crush injury to the chest. It may or may not involve injury to nearby structures. These injury mechanisms... I'm sorry? Oh, I don't know if I'm hearing someone else. Anyway, these injury mechanisms therefore likely require a relatively large amount of energy, which I think we should keep in mind as we discuss who warrants screening. So BCI can present as numerous different things. First and most common is arrhythmia. There are many potential structural abnormalities which would be identified on echo. And then there are also late complications, which present days to weeks after injury and are similar to those seen with myocardial infarction. Things like delayed rupture and septal injuries, complete AV block, heart failure, pericardial effusion, constrictive pericarditis. Unfortunately, these are pretty rare in trauma. As with most traumatic injuries, a grading scale has been developed. Grade 1 are probably what we see most often, and these are minor arrhythmias. Structural abnormalities without heart failure are grade 3, and those resulting in heart failure are grade 4. I wanted to take a few minutes to discuss the phenomenon of commodio cordis. I hope I'm saying that right, as it is something that was unfortunately brought to light recently in the case of Damar Hamlin, the Buffalo Bills player who suffered a cardiac arrest on the field. It is defined as sudden death due to cardiac arrest from BCI in the absence of a pre-existing disease and with no morphologic injury at autopsy. It is purely an electrical abnormality caused by high impact at exactly the wrong time. Impact during ventricular repolarization results in VFib, which then results in cardiac arrest. It is something to be aware of in usually young male athletes, and then other blunt trauma patients, as it is treatable with defibrillation and good post-cardiac arrest care. Diagnosis of BCI is challenging because the definition is a bit nebulous, and there's no single diagnostic imaging or laboratory finding. Of course, physical exam findings are important to identify as possible signs of BCI, but no one knows their sensitivity or specificity. Plus, we all know how hard it is to auscultate the heart in the trauma bay and actually hear anything. Chest X-ray and EKG abnormalities have decently high sensitivities, but are not very specific. And the validity of troponin levels is questionable, which we'll discuss in more detail later. Echo is perhaps the most important study to identify structural injuries, but it's really not a screening tool, and its sensitivity and specificity are also not known. So who do we screen? The answer is probably patients with high mechanism and some evidence of blunt chest trauma. So is that broad enough for everyone? So what about sternal fractures? This topic comes up all of the time in the ED. Numerous studies have been done on this topic, and as you can see, the incidence varies widely. So one report showed that among people with blunt cardiac injuries, anywhere from 17 to 72% will have sternal fractures. Among those with sternal fractures, anywhere from 2 to 42% will have blunt cardiac injuries. Now, this number is probably much higher in non-survivors, but they just don't make it to us. I'll highlight one relatively large retrospective study by Foken, published in 2022. And this group looked at 380 patients with sternal fractures and defined blunt cardiac injury by abnormal EKG, troponin, or echo. And they found that only 5% of patients with sternal fractures had a blunt cardiac injury. And none of these patients had an isolated sternal fracture. All of them had other injuries, with the only other statistically significant cofactor being pulmonary co-injury. Specific findings that were not significant with regards to increasing your risk of having blunt cardiac injury were displacement of the sternal fracture or retrosternal hematoma. So therefore, the paper argued that sternal fracture alone should not prompt evaluation for BCI. It also found that troponin levels are more likely elevated in the setting of a traumatic brain injury. However, this specifically contradicts a study by Whaley in 2002, which kind of found the opposite finding. It's found that 32% of patients with isolated sternal fractures had a blunt cardiac injury. And reading their methods, it was unclear if perhaps the Whaley group had a little bit more rigorous screening for blunt cardiac injury and maybe a little bit looser definition. So potentially this is why. But like a lot of the data in this topic, you can find arguments for both things. Fortunately, there are some guidelines about how to work up patients with suspected BCI. As many of you probably know, the Eastern Association for the Surgery of Trauma, or EAST, develops practice management guidelines for most things. Their most recent guidelines from BCI are actually from 2012, and they recommended obtaining an EKG in all patients suspected of blunt cardiac injury. This is pretty easy and something we obtain on most trauma patients. They recommend monitoring all patients with abnormal EKGs. If anyone is hemodynamically unstable or has a persistent and significant arrhythmia, an echo should be obtained. Laboratory workup is less clear, with troponin measurements recommended only as a level 3 evidence, and then where BCI is suspected, which I think is a little vague, and so I think that warrants further discussion. The one thing that most people agree on with regards to biochemical evaluation of blunt cardiac injury is that CK is not helpful. But how should troponin be utilized? Well, first we must remember that troponin levels don't start to rise until about 3 to 4 hours after injury. Therefore, a troponin level obtained with initial trauma labs in the trauma bay is probably useless, with a high risk for false negativity. So 2 prospective studies have looked at the utility of troponin levels in asymptomatic patients with suspicion for BCI. What they found was that troponin, when measured approximately 4 to 6 hours after injury, has a negative predictive value of almost 100%. This means that if you suspect BCI and the patient's troponin level at 4 to 6 hours normal, you probably don't have to worry about them having a significant injury. The addition of a troponin level to EKG can catch those who are still at risk for clinically significant BCI despite having a normal EKG on presentation. And in a prospective study from 2003, this was about 7% of patients that had a normal EKG but an abnormal troponin, and so those patients then warrant observation. So we'll talk very briefly on the management, as the management for BCI is really dictated by the particular injury. Management of arrhythmias in the setting of trauma is really the same for those without trauma. Cardiogenic shock mandates medical management. Cardiac tamponade or other severe structural abnormality warrant surgical intervention. So the real question is, who should you observe and for how long? Current recommendations are to observe patients for 24 to 48 hours with telemetry to assess for the development of clinically significant blunt cardiac injury. The main point to make here is that there's no specific treatment for asymptomatic blunt cardiac injury. There's no specific thing to do to mitigate the risk of developing clinically significant BCI. Rather, we are just monitoring patients in order to catch it when it occurs. Therefore, I think the real focus on diagnosing BCI is to develop an algorithm that will catch those at highest risk for a clinically significant BCI and prevent unnecessary hospitalization in those at low risk. So here's a proposed algorithm. It's based largely on the EAST guidelines, but with hopefully improved clarity on biochemical evaluation. So first, if you suspect that a patient could have a blunt cardiac injury, they would enter this algorithm. And I would suggest suspicion with any patient who presents after a high energy blunt mechanism with evidence of chest trauma, specifically if they have pulmonary co-injuries, so big pulmonary contusions, as well as blunt aortic injury. And you can possibly exclude those with isolated sternal fractures, meaning that if it's, especially a low mechanism isolated sternal fracture probably doesn't warrant workup for this. If the patient is unstable, then the stat EKG and echo are required. This should lead to ICU admission as well as any indicated intervention based on those echo results. Now, if the patient's stable, then the next step is to obtain an EKG. If that is abnormal and different from EKGs on file when we have them available, then the patient should be admitted to tele for 24 to 48 hours. If it's normal, then a troponin level should be drawn 4 to 6 hours later. And if that is abnormal, then the patient's admitted to tele. If it's normal, then the patient can be discharged to home or admitted without cardiac monitoring if they require admission for another reason. So of note, echo here is not used as a screening tool for BCI. Rather, it's helpful as a diagnostic tool for hemodynamic instability. You're specifically looking for things like pericardial effusion, wall motion abnormalities, valve incompetence, and septal rupture. I think it's very important to perform a bedside echo, or what we call a POCUS here, immediately. If you don't have that skill set, many ED physicians do. I think, oftentimes a stat echo is really not immediately available, especially if it's 2 a.m. And so really focusing on evaluating the heart by ultrasound yourself or with one of your ED colleagues, I think is critical in these patients. Now I'd like to switch gears and talk about BCVI, which is just as frequently discussed, but perhaps is very different with regards to management. As most of you likely know, the evolution of CT imaging has dramatically changed our ability to diagnose many conditions, and this is especially true for blunt cerebrovascular injury. While historically it was only diagnosed with formal cerebral angiogram, and or in the setting of neurologic symptoms, the historical incidence was less than 1% and stroke rate was like 50%. However, BCVI is now almost exclusively diagnosed via CT angio. And with very standardized and clear diagnostic criteria, the incidence is now reported between 1 to 3% of blunt trauma patients. But this, of course, requires that a CTA was obtained on the patient. The stroke rate is much lower at 10 to 25%, and the stroke-related mortality ranges in the literature from anywhere from 10 to 50%. The potential mechanisms of BCVI involve direct injury to the vessel, indirect injury from a fracture fragment, and then neck hyperextension. Of course, the thing we are worried about with BCVI is stroke. So stroke occurs due to either luminal occlusion due to platelet aggregation or hematoma, which is exacerbated by a low flow state of the patients that are in shock, or due to thromboembolism of the platelet aggregate that forms at the site of injury. Sometimes this occurs at the time of injury, but more commonly it occurs 10 to 72 hours after injury. So this begs a question: is there anything we can do to prevent that later stroke from occurring if we know the BCVI exists? Again, as with all injuries, there's a grading scale. The main point of differentiation is between grade 2 and grade 3 injuries. Grade 3 injuries involving having a pseudoaneurysm, because this is where the management potentially diverges, and we'll discuss that later. As you can see in the far right column of the table on the right, there's a significant difference in stroke incidence based on the grade of injury. The higher the grade, the higher the risk of stroke. And this probably leads to some of the variation between reported stroke rates in different cohorts. So how do we treat BCVI? If a patient presents with a stroke, then the management is the same as a non-traumatic stroke, but often limited by contraindications to systemic anticoagulation and TPA. The real question is how, if at all, should we treat asymptomatic BCVI? Do we just observe and do nothing, as we do with blunt cardiac injury? Or do we treat with antiplatelets, anticoagulants, endovascular interventions, or a combination of the above? The reality is that there are no high-powered randomized controlled trials to tell us, so we're really limited to the data we do have. A very good systematic review was published in 2021. And it involved reviewing studies of asymptomatic patients with BCVI diagnosed on CTA. They specifically looked at stroke rate and vessel healing. Of note, like all systematic reviews, they were limited by the quality of available studies. Most were very small studies with high risk of bias, and only 3 were prospective. Only 8 had more than 100 patients, and they were determined to be too heterogeneous to perform a meta-analysis. Nonetheless, I think the review was still helpful. It revealed an overall stroke rate of about 25%. And it showed that stroke rate was less with some kind of treatment. There was no real consensus about which type of treatment was better than the other. We still don't know what medication is best or what dose of that medication is best. But what has been made pretty clear in the literature is that some treatment is better than nothing. So numerous studies have tried to compare aspirin to heparin, but none are high-quality RCTs. Most of them are observational. While no significant difference has been identified between the two, there was, again, a reliable difference between either of those to no treatment. Again, some treatment is likely better than nothing. The nuances of endovascular treatment of BCI is outside the scope of this talk, and I really do welcome any vascular surgeons or neurosurgeons who may be listening to weigh in. However, endovascular treatment is considered for higher grade injuries, specifically grade 3 and above. These studies available are largely retrospective or observational in nature. Some, such as studies by Edwards and DeCoco, report good outcomes, including delayed stroke rate of as low as 4%, and low complication rates, including Edwards, who reported 0 complications. And then they also report that there's no difference between medical and endovascular treatment, despite higher grade injuries being managed with endovascular, which they concluded meant that the endovascular treatment was better for higher grade injuries because it brought that risk down to the same as lower grade injuries treated medically. But again, not really a head-to-head comparison. Other studies, such as that by Burlow in 2014, really raised concerns for higher rates of procedural complications with no change in outcomes. So that study, was a pre-post with how they treated patients before 2005 and how they treated patients after 2005, before they were doing a bunch of endovascular intervention, after they were doing essentially none, and their stroke rate didn't change. So the decision about whether or not to intervene endovascular is really a nuanced one that will be made by the consultant. So I've said that we should probably treat those with blunt cerebrovascular injury with aspirin or heparin, but the obvious reaction to that is that many of our patients will have a contraindication to one or the other. The most common contraindications are ongoing hemorrhage and TBI. Initiation of an antiplatelet or anticoagulant, should wait until hemostasis is achieved, but timing in the setting of TBI is perhaps less clear. There is one study by Dr. Colcutt that retrospectively evaluated patients with combined BCVI and TBI over 10 years. Of note, there were only 77 patients in that time frame. They found that the overall stroke rate was 27%, with a very significant difference in those that were treated versus those who were not, at 4 versus 57%. Of note, hemorrhagic deterioration was not different between the two groups. Now, the study has to be interpreted with caution because, likely the more severe TBIs had a delay in or deferment of treatment. So again, not a true head-to-head comparison. However, it does raise the argument that perhaps TBI is not an absolute contraindication to treatment of blunt cerebrovascular injury, and we really should be trying to initiate treatment as soon as it is safe from a neurosurgical standpoint. Based on this data, it does look like asymptomatic BCVI is an actionable diagnosis. One whose devastating complication of stroke can perhaps be prevented with early initiation of treatment. So who do we screen for it then? Some would advocate screening in those with established anatomic risk factors. Others would say everyone. Numerous groups have developed their own screening criteria. You'll see here the modified Denver criteria. That's probably the most commonly used. There's also the Memphis criteria and the Boston criteria. But what I point out is that these tables are pretty long. And I think a fair amount of things to remember when you're in the trauma bay and seeing the initial images and reports from CT head, face, and C-spines. Yeah. So then recently there's been a push to apply more liberal screening protocols for blunt cerebrovascular injury. An observational study by Dr. Stein's group at Shock Trauma was performed where they obtained a CTA as part of their traditional PAN scan. And that revealed an overall incidence of 1.2% in blunt trauma patients. Of these, 78% had an anatomic risk factor. So that means that 22% would have been missed if they had used the more specific screening protocols. Again, they noted similar results with regards to stroke rate as all the prior studies, that any therapy significantly reduces your stroke rate. Harper et al. Reported similar findings with 16% of patients with BCVI having no risk factors by Denver criteria. They even reported a relatively high rate of patients with lower energy mechanisms, including ground level falls. So the problem here is that it is unclear what the severity of those injuries were and what the stroke rate in this cohort was. I think that's the biggest challenge reading through these papers, to know, were these all grade 1 injuries? Did any of the patients that were found by the liberal screening protocol develop stroke? Because if we adopt that more liberal protocol, then will we find more injuries and prevent more strokes, or will we just find more low-grade and clinically insignificant injuries that would have never required treatment? And I don't think this question has been answered clearly. So first, I'll discuss our protocol that we currently have here at BJH for blunt cerebrovascular injury. It requires screening with CTA of the neck through the circle of Willis for anyone with a neurologic abnormality not explained by their known injury pattern. And I want to make a particular note that this applies to patients in the trauma bay as well as patients admitted to the floor or ICU. And so that means that if on post-injury day 1 or 2, they have an acute neurologic change, we're sending them down for a stat head CT. We should probably also be including a CT angio of the neck as well. Asymptomatic patients should be screened if they have specific associated injuries, which are listed here. Again, some could argue that this list could be a little bit difficult to remember and easy to miss patients that warrant a CTA. I think this happens all of the time where we're sending patients back for CTA after our initial CT imaging, and that it was either recommended or not recommended by the radiologist, but you really have to have be thinking about this to not miss patients that you need to send back for that additional imaging. We have specific recommendations for consulting either vascular surgery, neurosurgery, or neuro-IR, depending on the location of the injury. Our protocol recommends treating all grade 1 and grade 2 injuries with aspirin, though one can consider full heparinization if the injury pattern looks significant or there's additional risk factors. For grades 3 to 5, we should consider procedural intervention, which would be performed by one of the aforementioned consultants. If none are given, then aspirin, if none procedures are pursued, then aspirin should be given. I think one challenge we run into somewhat frequently is waiting to treat the BCVI when otherwise not contraindicated, because we are waiting on final recommendations for consultants. Our consulting services are very busy, and their attendings may not view the CTAs of low-grade BCVIs until the following day. So I would therefore argue that unless there is a grade 3 to 5 injury where endovascular intervention is being considered and that answer would therefore be obtained quickly, we should be treating all of these patients, again, in the absence of a contraindication, with aspirin and not waiting for confirmation. Because we know that most strokes occur within 10 to 72 hours, so prompt treatment really is critical. So has anyone changed their minds about whether we're over or underdoing it with BCI or BCVI? Are these more or less common than we thought? Do these conditions warrant more liberal or perhaps more conservative screening protocols than we currently use? In the case of blunt cardiac injury, are we unnecessarily screening and observing patients, thereby wasting hospital resources? In the case of blunt cerebrovascular injury, are we preventing strokes or just adding to selection bias? I think the big reality is that I don't actually have the answer to these questions, but after reading the somewhat limited data on these topics, I took away a few key points. First, the evolution of high sensitivity laboratory tests, CT quality, and ultrasound clarity and widespread use are all impacting our ability to diagnose these conditions. I fully anticipate that with time, these will evolve further and diagnostic criteria and management will change. This is a reminder that we should be reviewing our patients' EKGs personally, and I also encourage us to utilize bedside echo more often, especially when there was any sign of hemodynamic instability and TTE is not available stat. At this time, there are no real treatment options to mitigate the complications of blunt cardiac injury, but these do exist for blunt cerebrovascular injury. So I think there are two separate goals really when diagnosing these conditions. With BCI, the goals are to identify injuries at risk for becoming clinically significant and rule out those that are not in order to prevent unnecessary hospitalizations. With blunt cerebrovascular injury, the goal is to identify all injuries and then initiate treatment to prevent strokes. The key is to treat early, and any treatment is likely better than nothing. So thank you all so much for your time and attention. I finished a little early, but I welcome any comments, and I'm happy to answer any questions.
Thank you, Maggie. Let's see if there's anything, nothing in the chat yet. Does anyone have any comments, questions, anything they want to add?
Yeah. Hello.
Hello?
It's Doug. Can you hear me?
Hey, Doug.
How you doing? My question for Maggie, or maybe a point, is I still think we're looking at some of the data on troponins wrong for blunt cardiac injury. When you and or East recommends getting a troponin at 4 to 12 hours to rule out blunt cardiac injury, that fails to understand what happens when there is a positive troponin. And people get treated exactly as if they have a blunt cardiac injury, when we know most of the time that's not the case. And in fact, there's a whole lot of false positives, and we know that is the case. So all of a sudden, in a hospital that's constrained with resources, we're admitting people because of a troponin elevation, and we don't know what to do with that because these are asymptomatic by definition. And I'm not really sure I know what to do with an asymptomatic blunt cardiac injury, even if it was actually a blunt cardiac injury. So I think by getting troponins at all, the negative, we're absolutely right, a negative troponin does rule out a blunt cardiac injury, but the positive troponin causes such a cascade of downstream events that use resources and money that I'm not sure that it's worth it, because I've never seen an asymptomatic person keel over and die, ever, in 22 years.
No, that's totally.
East has the same problem with their recommendation, is that they think it's cheap, but it's not, because the contrary is it's not.
Fair. No, I think that's a very fair point. And, the data, at least that I saw, was that, maybe about 7% of patients will that apply to. So that's not a tiny number. That's still a lot of patients that are, going to be observed then that may not have otherwise been observed. But I think the point was that you catch those small amount of people, and then, you do have to observe them for about 24 hours or so, and you're, observing them for potential arrhythmias. But I think the key point is not to obtain a troponin at a time interval that doesn't mean anything. And then also, I think the biggest challenge with EKGs, at least in practice, is that so many of our patients are elderly and have abnormal EKGs and may not have something to compare it to. And then you don't know if you're going off of just a chronic abnormality or if this is actually from the injury. And that's also something that's frequently discussed in the literature, and I think is a big factor on this wide variability. So I don't have a perfect answer with you when it comes to when it comes to troponin, but I don't think it adds a giant amount of patients to that list of people that are going to be observed. And as of now, with the data, I don't know that it's something that can totally be ignored if you're taking those recommendations.
Well, a couple of things just in reply.
Yeah.
First of all, we don't actually know the number of negatives, because we don't know the number of people who actually had blunt cardiac injury when they're being diagnosed by troponin. So we don't even know that false negative or the false positive very well on those numbers. But again, practically in my career, and if you read through the papers that East looks at, no one ever reports an asymptomatic blunt cardiac injury that just up and dies. You don't see that report anywhere. So we're admitting people that don't need to be admitted, and even if they have a blunt cardiac injury that doesn't show up on EKG and does not show up with hemodynamic instability, is it clinically relevant to do anything for them? And the answer is usually no. The people that have blunt cardiac injuries that need any kind of treatment or intervention all present themselves quite clearly. And I also do not think that we are bound by 10-year-old criteria that aren't even by the grade criteria, and it's level 3 evidence, which means no better than expert opinion, which at this point I'm not sure is valid. You can look at the literature, the paper they based it on, and I don't think it justifies the expenditures. But it was a good review. I like it all. I just don't think we don't know what troponins are useful for. Once you get a positive, they end up getting a bunch more positives. I, by the way, completely agree with you that old people are not really in this boat because they can actually have MIs.
Mhm.
If there are any other questions or comments, I was also going to say something about blunt carotid BCVI, which I think is a great review you did, and then important to look at all that. I don't know if it's published yet even, but I think it was at East. Now that I saw it, but the they looked at just screening everybody above and beyond Denver criteria that had either a head or a C-spine CT already, and it's actually cost effective because of the number. It doesn't take a lot of missed strokes to prevent to make the quality adjusted life years really go up, especially in the young trauma population. So it's one of the things I took home from the meeting and looking at our criteria and should we make it more liberal. My only concern with doing that, as you guys know, is more of a practical nature of getting a scan in a rapid fashion that includes an arteriogram for the CTA, but also doesn't miss the venous phase to the liver and spleen, which are also often vitally important at the same time. So I think we should be looking at that and hopefully having a radiology protocol to make it easier.
Yeah, I agree. I mean, I think after looking through this data and I've, heard some of the talks that you're talking about, I didn't hear the cost effectiveness one, but there's certainly a lot of talk about more liberal screening protocols. And I think it makes total sense. If all of us have probably had at least one patient that we could remember who had a devastating stroke with a blunt cerebral vascular injury. So I think anything we can do to try to prevent that is key. But it is going to take, I think, buy-in from both the trauma team, radiology, and the radiology text if we're going to change this, because there's a lot of kind of confusion and pushback, I think, when we're trying to add on these images. Especially if we're not routinely getting them, because there have been times where we've gotten them in, high speed MVCs with ejection and they're getting pan scan and we say, yeah, let's just get the CTA right away. And if that became more common practice, I think it could be much more efficient. Because the amount of times we send a patient back for CTA after they've gotten all of their imaging is also cumbersome, I think, to the ER staff as well.
This is Armstrong. I just wanted to say something real quick. And this is mostly related to the evidence. I think, I think you touched on it. You in blunt cerebral vascular injury in particular, you do this all comer screening. And if you don't, supposedly you miss 1 in 3 of those injuries. And then how many of those are clinically significant? That's really the question. We don't know. But I think for me, in practice, and knowing that information and then seeing a number of devastating strokes, of course, this is through the anecdotoscope, I have become much more liberal in ordering the CTA neck before, not as a reactionary thing to a known injury, but before we know what their total injury pattern is, especially in high velocity trauma. Anyone who comes in intubated that hasn't been scanned yet, anyone who has a neurologic findings that aren't quite explained by previous imaging, and that kind of comes with those pre-hospital intubated patients. And I have no regrets. I have no regrets about them getting just slightly, maybe just slightly more contrast and an additional costly study, as long as they're getting aspirin. I remember John Holcomb used to say that basically everyone, he's a controversial figure himself, but he used to say that as soon as you do the roll, he would give someone prorectal aspirin. That's he might have been joking, but that's what he used to talk about. That's how adamant he thought, like, well, I can deal with the aspirin bleeding. It's I'd rather them not stroke. And of course that's a little extreme, but I feel like we under screen potentially here. And I feel like they shouldn't have to go back for another scan. That's personal opinion.
Yeah, I agree. Thank you.
I just put in one little in the chat. The case of high speed and otherwise is also difficult because there was a girl named Brittany Cecil who was at a Columbus Blue Jackets game and she got hit in the head in the puck and just probably snapped her neck a little, and her circle of Willis clotted off 12 hours later and she was dead. And most people wouldn't even think of that as a major injury. She didn't even pass out. They thought she might have a concussion or head hurt. And so it just shows that it doesn't have to be a high-speed MVC or otherwise to cause a problem. Have any spine fractures. She had no intrinsic head, none of those criteria. Yet it was a 13-year-old that had the problem. So I think we should be broadening out a little bit, just a little bit cognizant of what it means for the rest of the delay in the scans, and cognizant of what it means perhaps with a whole lot of dye, depending on how much you particularly worry about that problem or not.
Does it change the rest of the scans if they protocol in that CTA for the neck when you're getting that trauma pan scan?
I can't say with absolute certainty, but it shouldn't. They should be able to protocol it so that you're still getting all of your correct phases. And that's kind of what Dr. Schur was alluding to before to make, I don't know if Dr. Schur, if you have a better answer than I have, but they should be able to get all of the same images.
The problem is you usually want the arms up for abdomen, chest, abdomen, pelvis, and you want the arms down to do a CTA of the neck, because you want to get the arms out of the area where you're trying to beam across and see the close data for arteries. And then the second thing is, depending on how good your tech is, you should be able to do the CTA ahead of C-spine, then go down and do the chest, abdomen, pelvis. But if they're not quick at doing it, you miss a venous phase. And sometimes, to be honest, the spleen and liver are more important at that moment than the CTA of the neck. So the problem is that without a good protocol, it may not happen. So I think one of the things, if we change our protocol, and by the way, when we wrote our protocol, we had neurosurgeons, vascular surgeons, intensivists, and radiologists, neuroradiologists all involved in that, and neuro IR for that matter. So if we were going to change our screening thing, we certainly need to get our CT scan attendings involved and get the techs to do it in a quicker fashion, because we've all been frustrated by some 40-minute CT scans, and that's also not okay.
Thank you.
Any other comments?
Oh, Maggie, that was a great job reviewing all that stuff, because this isn't easy yet, and that's why we at least have some protocols, at least guide us somewhat. If we need to change things, we will.
Maggie, I was going to ask, with your review of the literature, will it change your practice in any way?
Yes, I definitely will be more liberal with screening for a blunt cerebrovascular injury. Even more than I was already feeling. I think I'll push for that more. And I think I also, it came up just in Morning Report the other day about a patient with a concern for BCVI that wasn't, hadn't received aspirin yet. We're waiting on final recs. And I think really pushing our team that those patients need aspirin immediately if they don't have another contraindication. And then with regards to blunt cardiac injury, I mean, I do think we're probably overdoing it. There's been a lot of patients. I know Dr. Schur has appropriately scolded me before for, working up, isolated sternal fractures with low mechanism. And I think those are probably, really unnecessary. And so trying to really find those that I think are more clinically significant, and then having a more liberal use of bedside echo, especially in the ED. I know our ED colleagues are so good at them. And then looking anytime there's a question quickly, I think is also critical. Sorry, I didn't scold. You taught me appropriately, Dr. Schur. I appreciate you. I hope that answers your question. And if anyone else has any other questions or comments,
Well, don't see anything else in the chat. Thank you, Maggie.
Yeah, thank you.
Thanks everyone, and look for the next conference. I'll send out the invite at some point shortly. Thank you, guys.